So we are now open to questions. Are there any questions from the floor? So I would like to ask you, I'm really interested in angiostrix because we have cracks in high myopes, and I'm thinking about the differences between angiostrix and cracks. And in angiostrix, by OCT angiography, you detect CNV in other than macula or peripapillary radiating streaks. How often do you detect CNV in other areas?
Yes, actually, in our study, the CNV we detected were mostly macular, were mostly foveal, but in about 15% of the cases, we detected CNV that were peripapillary.
I see, I see.
Generally, it's the most common location, but all of our patients actually had most of our patients, 90%, had long-standing CNV. So I think that the initial CNV may have been closer to the papillary, to the intermacular papillary area, but then extended gradually to the macula.
I see. Well, thank you so much. Very interesting talks. And yeah, Rick, please.
The macula is 6 millimeters in diameter, right? And we have many posterior ciliary arteries coming up into that area. And if a CNV lesion is a couple millimeters in diameter, wouldn't by chance alone we would see a CNV lesion over a perforating blood vessel?
Yes, thank you so much. Actually, in high myopes, penetrating site goes toward periphery, so only some short posterior ciliary arteries are left around the macula. And some patients even don't have any penetration site of short posterior ciliary arteries in the macula. So in the patients who happen to still have short posterior ciliary artery in the macula, they have some risk of developing CNV. And if they don't have any penetration site at all, I think they will have no risk. Is that what you asked me?
No, but
So.
Because you only found the penetrating vessel
Yes.
in 11% of CNV cases.
Yes.
Which could be chance alone, if you think about the mathematics of it. Because the macula being 6 millimeters in diameter is a pretty small place, and there are some vessels coming up, and CNV has a diameter of its own.
Yes.
The chances are they could just by accident, 11% of the time, be lying over a penetrating vessel.
Yes, but in our results, yes, maybe it's a limited number of patients, but we detected frequently penetrating vessels in the CNV. Is that? Yes. Yes, Maji?
The question is for you, the presentation about the perforating scleral vessel. Do you think using the swept source helped you in that? Because we used to have the spectral domain, and we don't see much of the sclera and the choroid at the time. Do you think the percentage is high because you are using the swept source, not the spectral domain?
Yes, that's right, yes. Not spectral domain. And by using swept source, we can see the outer surface of sclera, so we can see where vessel penetrates the outer surface of sclera, and also in the entire course from outer surface to the choroid. So then only with a swept source, and also in pathologic myopia. By this combination, we can detect this vessel.
My second question is it easy to find it, or you are looking for it? I mean, sometimes we do vertical, horizontal line scan and forget about it. We know that it's high myopia, there's not much complication, we know there is CNV over there, but is it easy to find it, or you are just looking for it in every high myopia?
Yes, thank you so much. It is very difficult because although we have seen many images, we didn't notice until recently. And we try to look at 3D images by manually moving and see each section, and then we can find it. So yes, it is easily overlooked.
Thank you.
Thank you. Any other questions? So for your talk, I'm interested in the pattern or neovascular AMD, and I would like to ask you all, in addition to a dead tree pattern or bushy pattern, maybe the shape of CNV itself might suggest some activity? Because I'm thinking about angiodystryx. Maybe it might be linear, yes, if it goes through the Brooks membrane. So linear CNV is inactive, or does it happen to?
Actually, in Professor Kerker's study, they used shape as a criteria for CNV pattern. But in our study, unfortunately, we did not use the shape of the CNV. We only looked at the tiny ramifications. But I think that linear might be inactive.
I see.
As you suggest.
And how about in type 1 NV? Does shape is...
We didn't compare shape of this membrane. Our decision factor was to find this membrane. If it really exists, it behaves like naoma, like tumor, I can say, in choroid. And if it really exists and is active, for us is the most important thing that you must perform injections 1 in 2 months. So it's out of sense to perform OCT every month. And it was, for us, the most important. And this first group was created to establish less OCT scans. And in second group, the idea is that we must perform a lot of scans because it's completely unpredictable. It's only workflow.
I see. Thank you so much. Sorry about asking you so many questions, because I feel similarity. Yes. And I'm wondering why angiodystryx have a radial pattern around the optic nerve, because in high myopes and angiodystryx, both diseases have a weak Brooks membrane, but why crack pattern is different and location is different?
It is a very interesting question. But unfortunately, I do not know the answer, and I haven't seen it in the wide literature I've read on the subject. So maybe it's maybe the reason may be histological, and it could really escape common sense.
Thank you very much. Sorry about the difficult questions. Do you have any other questions between speakers?
No, just a comment that it's very important to the use of OCT angiography and MACTEL-2, because when you see it at the fluorescein angiography, when there is a leakage on the early frames, they may occult some of the deep layers. And with the OCT, we don't have that trouble. That's very important, and it's the main feature of to use the OCT, angio-OCT, to this special entity. And it's very important to perform this examination so we can look at those changes on the deep and the superficial layers.
I see. So for you all, so what kind of function do you want for OCT angiography in the near future to detect for the diagnosis or treatment of MACTEL, angiodystryx, and wet AMD? So what other functions do you want, or current function is okay, or if you have in mind some specific functions maybe useful in the future, could you please?
Maybe the panoramic OCT, that we can see all the changes, not only in the posterior pole, because all the retina around, so we can see the changes in some ischemic diseases like the diabetic retinopathy. Is very important to see all the features of the vessels. I think that will be a very important improvement. I know that they are working out this issue, and I hope they can solve it very soon.
I see. So wide field OCT angiography.
Yes.
I think it is interesting because, for example, angiodystryx, visual acuity decrease is caused by macular CNV, but the disease is already around the optic nerve. So, and also recently, Dr. Won-Ki Lee in Korea reported an article in Ophthalmology showed that in macular serous retinal detachment patients, they detected many laminar defects in the optic nerve. So what appeared to be thought as macular disease might not originally start from macula, so which is interesting. So by looking at wide view, we might detect abnormalities in somewhere else. Yes, yes. Wouldn't you?
Still, the issue currently is that the wider the acquisition window, the lower the resolution. So
Yes.
there
yes.
has to be a compromise between the
Yeah.
acquisition time and the resolution in
I
these wide
see.
windows. If not, it'll be
Yes.
very difficult to see small defects when having a very big.
Yes, the resolution is
window.
an issue. Thank you so much. And
Probably, I think that problem is angio-B is that
Angio-B.
if scars are very extensive, I think that angioflow is not visible. I don't know. I think it's technical part of it.
yeah.
Sometimes it's very strange why I don't see. There are vessels, membrane is visible, but I don't see angioflow. Why? I have, as I told previously, I have performed 2,000 angio-B in last year, and sometimes I don't know why I don't see. It should be, I think.
I see.
Maybe
yeah.
next
Next. Yeah.
generation of equipment.
Yes, and for me, a 3D OCT angiographic view of new vessels might be, I would like to see if we could obtain that image more easily, that would be great. For example, as Dr. Ogura showed, and where the new vessels come is, if we can see that information, yes, it would be also useful. Yes, any other questions? So, thank you very much for everybody. I would like to conclude this session, and thank you very much.